Everybody, and a very warm welcome. My name is Julia Priestley and I'm one of the joint CEOs of the BTF. We're very pleased that so many of you have been able to join us for tonight's meeting. I believe we've got a mixture of patients and medical professionals, and you're all very welcome. Our webinars to date have focused on specific thyroid disorders and how they're treated and managed, but this time we're going to be doing something slightly different and looking at the world of thyroid research. For those of us living with thyroid disease, it often feels that when compared to other health conditions, it's an invisible condition that's ignored and underfunded. And our members and others we come across regularly ask us what research is actually being carried out, what are the developments that are going on, and when and how will the treatments change. So we thought that having a webinar that focused on research would help us all understand more about this and give us all the opportunity to ask some questions. And before I introduce you to our speakers this evening, I just wanted to give a quick plug for the British Thyroid Foundation and the work we do to support people. Almost all of our funding comes from membership fees and donations. So if you'd like to support our charity, enable us to continue to provide free information events like these, please do consider joining the BTF or making a donation, however small. And our charity has a long history of supporting thyroid disease and research into it. Since 1997, we've invested over £500,000 into research into thyroid disorders, and we're very proud that our annual research fund has been running now for 25 years. And even though it's a very small award in the world of research, it's only £20,000, ours is, as far as we're aware, the only dedicated fund for thyroid researchers exists. And so we're really working hard to ensure that it will continue. And all of the money that we've put into thyroid research comes from our patients and generous fundraisers. So now, without any more from me, I'm delighted to pass you over to our chair for this evening's webinar, who will introduce our speakers. Dr. Nicola Zammit is a consultant endocrinologist, and she's a clinical director at the Edinburgh Centre for Endocrinology and Diabetes. Nicola has a particular interest in thyroid eye disease, and she runs the joint clinic in Edinburgh. So without any more, over to Nicola. Thank you.
Thank you, Julia. And thanks very much for the BTF for setting up this session. I gather there's around 200 people registered for it, so I think that tells you how popular a topic this is. And we're in for a real treat this evening. We've got two very different but complementary researchers, both from the Cardiff University School of Medicine, who are going to take us through, I think, a fairly broad range of research approaches. So we're going to have a talk from Professor Marion Ludgate first, followed by Dr. Buchi Okosieme afterwards, and then we'll take some questions at the end. The talks really are going to be about the principles of research in general, and then using some specific examples of research to illustrate particular conditions or particular advances that have been made. But really just want to clarify that we won't be able to answer specific questions about people's individual conditions. So we won't be able to answer questions about, your own specific thyroid condition and what the research says you should do. That would need to be dealt with your own doctor. But our first speaker, Professor Marion Ludgate, is a basic scientist. Our second speaker, Dr. Buchi Okosieme, is a clinician. So I think they're going to take us really from bench to clinic in a really nice overview this evening. So with no further ado, I'll move on to introducing Professor Ludgate formally. Marion was introduced to thyroid research almost 40 years ago by John Lazarus, who's one of the really big names in thyroidology in the UK. She's a basic scientist, and she's worked mainly in Cardiff, but spent almost 9 years in Brussels as well, where she was involved in cloning two of the main thyroid autoantigens, TPO, the thyroid peroxidase, and the TSH receptor. And I'm sure she'll talk more about both of these. She's got a number of interests, but within her lab studies, she's worked on thyroid eye disease and Graves' disease, but she's also been involved in more clinical investigations, for example, continuing the CATS project on whether thyroid screening is needed in pregnancy. So a real broad range from basic science to real clinical applications. Professor Ludgate, thank you very much. I'll hand over to you to tell us a little bit about how does research work.
Thank you very much indeed, Nicola, for this very kind introduction. And the first thing that I will do is try to share my slides with all of you so that hopefully you've got something to watch while you're listening to me speaking. So hopefully that looks okay. So I'm going to give you a little bit of an idea of how research works. And really, I guess that many people will be aware that when we do research, we really talk about three main kinds of study. The first of these is what we call in vitro research, using in vitro models. And essentially, this just means anything that's done in a test tube. So we're not talking about whole people, we're talking about perhaps samples of relevant tissue. And obviously, in our case, that might be thyroid tissue, it might be blood. And these are grown in some kind of culture system. And this gives us an opportunity to investigate disease processes and also test new drugs. The second kind of research study are in vivo models. And in vivo models, we use whole living organisms. And I think most of us would be familiar with the use of rodents, that's mice and rats. But the organisms may be as tiny as fruit flies or zebrafish, or as big as primates. But in fact, relatively little of this kind of research is still done. And then finally, the kind of top of the pyramid are those studies which are conducted in humans. And I'm sure we'll hear a lot more about that from Bucci. But really a human study can be observational, which means that we just measure different tests, blood tests and so on in patients. We perhaps track symptoms over a time period, or we can actually do a clinical trial to see about a new drug. So let's think a little bit more now about in vitro models. And as Nicola explained, really my main foci of interest have been Graves' disease. So this is an overactive thyroid. Obviously, you'll be aware of that. And also thyroid eye disease. I've done a bit on Hashimoto's, and you heard how I was very much involved with cloning thyroid peroxidase. So what kinds of in vitro methods do I use? Well, obviously, as I'm interested in Graves' disease, then quite often we have cultures of thyroid tissue. And we obtain samples from patients, always with informed consent, very different from the situation when I started out, where these kinds of samples would be taken without consent. These days, they all are. And when we put these in culture, it looks sort of fairly untidy and scruffy to start with, but then by using the correct culture medium and the correct conditions, we can actually end up with something that looks just like a thyroid follicle, which are these balls of cells, which obviously are the functional unit of the thyroid gland making thyroid hormone. The other thing that I'm very interested in is fat, which may seem strange. The reason for that obviously relates to thyroid eye disease, because people who have this problem, they have expansion of all of the material which is in the orbit. Some of that is muscle, but also a large part of the problem derives from the fact that the orbital fat grows. And so we collect samples of orbital fat. We also collect it from other depots, and we really compare the fat from the orbit with the fat in other places to try to understand why it is that an individual who's got hyperthyroid Graves' disease, when the rest of the fat in their bodies actually gets smaller, why does the fat in their orbit get bigger? And this here just shows you a fairly typical culture hood. Now, the culture hood is really about protecting the cells and the tissue cultures that we're working on rather than us, the scientists. And you can see here a bottle of culture medium. This contains all the nutrients that the cells need, and then the kind of disposable plastic, either wells or tubes that we use to grow them in. And then, of course, it's all sterile, and then we transfer it to an incubator to keep it in culture. But the good thing about in vitro work is that it's often a very good starting point to test a hypothesis or an idea. And I'd like to give you an example of just how we used an in vitro study to investigate a drug which is called bimatoprost. We'll call it BEMA for short. Nothing at all to do with Graves' disease or thyroid eye disease. In fact, this is a drug which is used in people who have a problem called glaucoma, which is when the pressure within the eyeball is too high. And BEMA can reduce the pressure in the orbit, and that then brings about some kind of comfort and treatment for the disease. Now, it was brought to my attention by a very good ophthalmology friend, Glyn Baker, who worked with me for many years, that there were reports that people who were treated with this BEMA drug for their glaucoma, their eyes could appear sunken. Now, we will notice the exact opposite of the kind of bulging eyes, the proptosis, that we see in people who have thyroid eye disease. And in fact, when we do scans of people who've been treated with this BEMA drug, it shows that the amount of eye fat in these people has been greatly reduced. So what we did is that we got samples of eye fat, and the way that we treat these is that we put the little tiny pieces of fat into a culture plate, and then the stem cells migrate out from the fat and cover the plate. We can then transfer it to other culture vessels. And one of the things we did was to see how quickly the cells grew in the presence and in the absence of BEMA. We also measured how well these stem cells that we obtained from orbital fat were able to form new fat cells with and without BEMA. And the results that we got really were very promising. It suggested that the growth of these stem cells was reduced and their ability to form fat cells was reduced. And so we did a clinical trial. So we had individuals who had inactive late-stage thyroid eye disease. And when we then treated them with BEMA for 3 months, in fact, we didn't see any benefit. But we think maybe we didn't choose the right kind of patients. Maybe we should have chosen those with active disease. Maybe we needed to try them for a little bit longer than 3 months. So that's an example of an in vitro model and how it can help us. Why might we need to use an in vivo model? Well, let's go back to the example of thyroid diseases, many of which are autoimmune. And when we say autoimmune, really what we mean is that the body's defense mechanism, for some reason, starts to think that the thyroid or cells in the orbit are foreign, as if they were an infection. And as a consequence, they start to make an immune response, and then you get disease. And we know that thyroid diseases run in families. So this immediately suggests that there is some very important genetic component to thyroid disease, in particular autoimmune thyroid disease. But if we look in large groups of twins, it is not impossible that one twin might have an autoimmune thyroid disease, but the other not, even when they're identical. So this really tells us that there are environmental factors that may be important as well. This can include our diet. Being a woman, we know that autoimmunity generally is more common in women. Smoking, all of these things can then impact whether we get this disease or not. So it's in this context, when we're trying to answer more complicated questions, that in vivo models can be very useful to increase our understanding. Now, quite rightly, and I'm sure you'll be reassured to know that all in vivo work is very highly regulated. It's controlled by a branch of the Home Office, which is called the Animals in Science Regulation Unit. And any kind of work involving animals requires at least 3 licenses. So that's the individual doing the work, and that requires a lot of training and taking exams before you get a personal license. It involves the place where you're doing the work to make sure that the facilities are as they should be and that the animals are well cared for. But it also relates to the actual project that the work is going to be doing. And as a consequence, this means that all work really is based on the principle of the 3 R's, which is that we refine the work we do, we replace them with in vitro models if we can, and we always reduce the numbers just to the bare minimum to be able to get meaningful results. So let me just tell you a little bit now of the model that we have of Graves' disease and thyroid eye disease. And as you can imagine, it involves injecting something. And the thing that we inject is what we call the thyrotropin receptor, which is essentially the thyroid on-off switch. And the TSH receptor is really what TSH binds, and that regulates the thyroid gland. Obviously, then in people with Graves' disease, they have antibodies that think they're TSH, and they then stimulate the gland the whole time in an uncontrolled manner. So we tried to start with lots of different kinds of mice, and all of the mice that we used are genetically identical. But we found that this kind of white mouse was very susceptible to being induced to have Graves' disease, whereas other white strains or brown or black mice, these did not have the kind of genetic makeup that enabled them to develop Graves' disease. So what we did, we've got these genetically identical individual mice. They're all female. They're fed the same diet. Half of them were injected with the thyroid on-off switch and half were not. So these mice, they develop the stimulating antibodies, which are characteristic of Graves' disease. And they also develop changes around their eye. So they get expansion of the orbital fat, very similar to those seen in thyroid eye disease. So one of the many things that we've done with this model, in one of the sessions, we collected the intestines to be able to analyze and compare what we call the gut microbiome in the mice treated with the on-off switch and those that were control. What do I mean by microbiome? So to start with, a microbiota is the collection of microorganisms, and that's the bacteria, viruses, fungi, and so on, that are all found in a particular niche. The one that we focused on was the gut, but we could have looked in the nose, we could have looked on the skin. There's lots and lots of different microbiota. So then the microbiome is the genome or the DNA content from all of these different microorganisms that are present in that particular place. And obviously, we've only known about them for a few hundred years, simply because we couldn't see them until there were microscopes. And then progress was made eventually with culture methods that meant that they could be grown in particular media, stained in different ways, and this is how they were analyzed. But now in the 21st century, the way that we analyze them is by looking at their DNA. And this is exactly what we did in our mouse model of Graves' disease and eye disease. Now, before I give you a summary, an overview of the results that we obtained, I just need to tell you about the main components of the gut microbiome. The word that we use is phylum, and you'll see they've got wonderful names. So this big pink slice of cake is the firmicutes. This slightly smaller are the bacteroidetes. Then we have actinobacteria, proteobacteria, and then in this blue segment are all the other kinds of bugs which are present in the human gut microbiota. And one very popular method of analyzing the microbiome is to calculate something called the firmicutes to bacteroidetes ratio. And this is a way of comparing microbiomes between one group and another. So what we found is that in our animals, those that had been treated with the TSH receptor, with the antigen, in other words, they had significantly increased F firmicutes bacteria and significantly decreased bacteroidetes when we compared it with the control mice that hadn't received the receptor. As a consequence, this FB ratio much higher in these receptor-treated mice. And also there was a very strong positive correlation with the amount of orbital fat, which means that the higher the FB ratio, the more orbital fat there was. So the more severe the kind of eye disease that they had. So this was a very interesting finding. But just because you can see that there's something that correlates with something else doesn't mean that's the cause of it. So the next thing we wanted to do was to see whether we could actually change the composition of the bugs in the gut of these animals. And the way that we did that, we used 3 different kinds of approaches. We used an antibiotic, which is called vancomycin. We used a probiotic, which is called Lab4, and then something that sounds quite yucky. We obtained poo samples from individuals. They were women who had very, very severe Graves' disease and also very severe eye disease. And we made a preparation so that we could transfer the gut microbiota from these people with very bad Graves' and eye disease into our mice. And the way that we did all of the modification, whether with the antibiotic, with the probiotic, or with these gut bugs from people with Graves' and eye disease before the immunization process began. So we'd really kind of primed the gut microbiota to be different before we started to induce disease. So what happened? Well, in the case of the antibiotic, if you remember, in the mice that have just received receptor, then we tended to get an increase in these F and a decrease in these. But when we treat the animals with an antibiotic before putting in the receptor, the firmicutes are very low, the bacteroidetes are very high. In those poor mice that ended up receiving the fecal material from patients who've got these conditions, the increase in firmicutes was even more extreme and the decrease in bacteroidetes even worse. The results with the probiotic were similar, but not as marked as with the microbiome transplant. So what did it do to disease? And here you can see we've measured the antibodies. So these are the stimulating antibodies that cause Graves' disease. Antibiotic decreases, the poo from the patients increased it. How about being hyperthyroid? Again, the antibiotic decreased the amount of thyroxine, whereas the material from patients greatly increased it. And really, it was as if we totally changed the composition of the microbiota, and as a consequence, we were able to make disease much less severe or much more severe. So what does this in vivo model tell us? First of all, it tells us that injecting the thyroid on-off switch, the TSH receptor, into mice induces the signs and symptoms of Graves' disease and thyroid eye disease, which really underlines and really shows us how important this antigen is in these 2 conditions. Then we can see that the gut microbiome in those mice treated with this receptor differ markedly from those that didn't receive receptor. So they've got a high F to B ratio, and this correlates with more orbital fat. Even more interesting, if we change the gut microbiome, we can make disease much worse by using material from patients with Graves' disease, or much less severe by treating with antibiotic. So from this, I think we can conclude that the gut microbiome and what is in it definitely contributes to the development of Graves' disease and eye disease. But what about in people? One thing to look in mice, another thing to look in people. Before I come on to that, let's just give you a little bit more background information about the microbiome. We inherit from our mums. And the thing which is interesting is that when a baby is born through the vagina, through the birth canal, he or she will have a very different microbiome composition than a baby who's born by cesarean section, because this baby will tend to have the microbiome from the skin rather than from the vagina. Similarly, a bottle-fed baby will have a different microbiome from one who is breastfed. And you can see that the human genome contains about 20,000 genes, which is really insignificant compared with the 1 million+ genes which are there in our guts, in our microbiome, and in other places as well. So what else affects the microbiome? Not surprisingly, what we eat. And the more diverse microbiota tend to be from people who have a very healthy diet with lots of fiber. I'm afraid alcohol affects the gut microbiome, but it's not all bad news. Some components of red wine are actually good for the microbiome, but personally, I prefer white. Smoking naturally affects the microbiome, and of course, stress. So anyone who's interested, there will be a little article about this on the BTF website in due course. So what about the microbiome and age? As you can see here, in younger subjects, then here we get the firmicutes being more predominant and the Bacteroidetes less. But the thing which really happens as you grow older is that you get a much less diverse microbiota, and this probably explains some of the problems associated with aging. So here is our study on the gut microbiome in human patients, a study called Indigo. We were able to recruit 59 people who had Graves' disease, 46 with eye disease of varying severity, and 41 healthy controls from 4 different countries. We collected their blood, we collected feces, because obviously we can't go taking the intestine from people, and a variety of other samples. Obviously, we measured the stimulating antibodies, we measured thyroid hormones, and we analyzed their gut microbiota. And here you can see the results that we got. So here we have the control. And the first thing that we can see, I'm afraid the colors aren't so great, but I think you can see that the firmicutes in the Graves patients and those with eye disease is a much bigger slice of the pie than it is in the controls. In contrast, when we look at the Bacteroidetes, a much smaller slice in Graves' disease and indeed in eye disease, just like we saw in the mice. And in fact, as this slide tells you, we saw similar changes in humans as in mice. So we had increased firmicutes and reduced Bacteroidetes and a much higher F to B ratio in people with Graves' and thyroid eye disease than human controls. When we then looked at smokers, there was no overlap in any changes that we saw in Graves' disease and changes that we saw in smokers. But when we analysed smokers and eye disease patients, we saw the same changes, and they were much more severe in the smokers, especially those who still smoke. The other thing that we found is that some bacteria from the firmicutes group were much more abundant in people who don't particularly respond well to thyroid, anti-thyroid drug treatment, and perhaps at the end of 6 months or more treatment, they still have antibodies. And of course, these are the people who are more likely to relapse and more likely to develop eye disease. So we were quite encouraged. The fact that we had the same changes in mice and men, despite the fact that humans are completely genetically different, they have completely different diets, we were really quite encouraged by this. How do we think it's working? So here you can see, we're talking about people who have got a predisposition to have Graves' disease or eye disease. If they've got a healthy microbiome, then we get a very good balance between these blue T cells, which really protect against inflammation and autoimmunity, and these red T cells, which really will drive autoimmune responses. In dysbiosis, which is mean that we've got some kind of imbalance, just like we saw in our studies, either we get an increase in these pro-inflammatory bacteria, which means that the proportion of these T cells that promote disease will be increased, or dysbiosis, this imbalance, can decrease the anti-inflammatory bacteria. And then we have too few of these regulatory T cells. It's a work in progress, and hopefully there's much more to learn. So on that note, I'll say thank you very much, and now look forward to passing over to Buchi. Thanks very much.
So Marion, thank you very much for an excellent first talk, which has really taken us from cells in cultures through animals, through application to humans. We'll move on to our second talk, and we'll take questions at the end. I can see questions coming in already. Please keep them coming, and we'll try and get through as many as we can at the end, but we can always answer any that we can't get through by email afterwards. So our second speaker, Dr. Buchi Okusieme, is a consultant endocrinologist at Cwmtaf Health Board in Wales, and he is also an honorary professor at Cardiff University School of Medicine. His core research interests are in improving health-related outcomes in patients with thyroid disease, and he's got a long track record of working with colleagues at the Cardiff Thyroid Research Group to achieve better understanding of thyroid disease treatment outcomes in a number of areas, including pregnancy, Graves' disease, and hypothyroidism. So having heard from Marion about how research works, we're now going to hear from Buchi about why research is such an important tool for improving health-related outcomes, and he's going to highlight some of his own research in people with Graves' disease and hypothyroidism to illustrate this. So Buchi, thank you very much. Over to you now.
Thank you, Nicola, for that generous introduction, and thank you to BTF for inviting me to speak. I'll just try and get my slides up. Okay, we can all see that. Great. So my core research interest, as Nicola said, is in improving health-related outcomes in people with thyroid dysfunction. So what I'll do today is talk briefly on why research is important and share some of my own research work, and then talk about how you can contribute or how you have been contributing to some of the research we do. So a simple definition for research is asking questions and answering those questions. So asking relevant questions, and there are different levels of research, clinical research, which I'll focus on, as Marian has talked about, in vitro and in vivo studies. So there are levels of research with the quality of evidence increasing as you go up. So at the lowest rung of the ladder are things like your expert opinion, editorials, and debates. It goes on to case reports and case series and anecdotes. And then you move on to observational studies and randomized controlled trials. And finally, the combination of these studies to make systematic reviews and meta-analysis. Now, all of these are important, and it's important that we have opinions and editorials and reports and series to ask the questions. And then we try to answer the questions with trials, and then we combine this in synthesis formation. I'm just going to give you some classic examples of studies. So this is a randomized controlled trial from the 18th century by James Lind, who was a Scottish naval surgeon at sea aboard the HMS Salisbury. And this was at a time when scurvy was rife among the sailors and seafaring men. And at the time, a lot of remedies had been bandied about by different opinionists and experts. And what James Lind did was divide his sailors into into six pairs, and fed them different remedies. One group got a quart of cider a day, some got vinegar, seawater, garlic, and a last group got 2 oranges and 1 lemon daily. This was a trial that was supposed to go on for weeks, but had to be stopped early because the group 6 with the oranges and lemon were the only group standing after a while. The other 5 groups became very unwell, and the guys in group 6 had to look after the rest of the group. So Lind was able to prove here that oranges and lemon cure scurvy, although it would take another 50 years before they realized it was a vitamin in it that did the trick. Why he could do that was because all the other variables were constant. They were on the same ship, they breathed the same air, they were drinking the same water, it was the same environment. So that's an example of how you do a randomized control trial. Now, the observational study, if you're old enough, you probably remember when it was cool to smoke, and doctors and scientists used to sort of endorse smoking at cigarette adverts. And in fact, I do remember doctors who smoked in the consulting room in the hospital. But all that changed from about the time Dahl and Bradford Hill did this study where they went to several hospitals around London and found those who had lung cancer and age and sex match controls without lung cancer. Lung cancer is in black, the controls are in white. And what they can show here is the amount of tobacco smoked daily correlates with the lung cancer, with those who smoke more, having more lung cancer, especially in women. And this was an example of an observational study. We've had our own sort of life-changing studies in thyroid, and I just want to highlight a few. The thyroid extracts, a Newcastle physician by the name of George Murray in 1891 injected a patient with thyroid extracts. And this was a patient that was dying, and this was a time when hypothyroidism was a fatal terminal disease, and patients died slowly from it. So what he did was inject this patient with sheep thyroid extracts, and almost miraculously, this woman made a full recovery and went on to live to her 80s. What I'd like to highlight in this timeline is that most of the common treatments we have for thyroid disease today all happened before the 1950s. So thyroid extracts, the identification of thyroxine, the thionamide, radioiodine, T3, and liothyronine. So the last sort of time of a new treatment being discovered was in the 50s, and in the last 70 years, we've sort of not had any new treatment, which in a way, you could say, yes, the treatments are effective, but it's also disappointing that we haven't improved on what we have. So this is important because thyroid dysfunction is common. About 1 to 4% of the population suffer with thyroid dysfunction. This is about 1 to 3 million people in the UK. This is a disease that predominantly affects women in the productive years of life. It affects them during their working lives and during their reproductive years when they're having babies. Most times those affected are caring for other people. So this is a disease that carries a lot of impact, not only on the patients, but on those who depend on them for care. This is what most thyroid clinics, including my thyroid clinic, would look like. So if you come in with hypothyroidism, you either start with antithyroid drugs. If that is successful, back to your GP. If it's not successful, then you go to the next stage, which is radioiodine or surgery. If that is not successful, either more radioiodine or surgery or more antithyroid drugs. Those who are referred with hypothyroidism are started on levothyroxine and discharged back to their GP. Most times this works, but sometimes you have a few patients who are caught in this loop where they have one unsuccessful treatment after another, one relapse after another. So they're caught in a sort of circuit, which is very frustrating. And that circuit may last anything from 5 to 20 years. So it was on this backdrop that we asked the question, what are the long-term consequences of early treatment of hyperthyroidism? And that's how that gave birth to the study on primary therapy of Graves' disease and cardiovascular morbidity and mortality. So the question we're asking is, does primary therapy influence long-term outcomes in patients with Graves' disease? Now, this was a study we did through a data bank, and this is one of the perhaps modern ways of doing this kind of research. In the time of Doll and Co., they actually went to the hospital, spoke to every patient, collected data from the patients. But what we do now is that you can do this through a data bank where the patient's details are sent into the data bank, they are linked with outcomes, and they are presented to researchers without the researchers knowing who the patients are or having the identity of the patients. I'll just run through the results here. You can see that there is an increased mortality and major adverse cardiovascular events in all patients. But when you break it down by treatments, this persists with those who have antithyroid drugs. It's not seen in those who have successful radioiodine treatments. It's also seen in those whose radioiodine treatment was unsuccessful, which makes you think that this is probably due to the effect of thyroid function. So to do that, we looked at the TSH of these patients after 1 year. So TSH is a marker of hyperthyroidism, and low TSH means that these patients are still hyperthyroid after 1 year. And you can see here, this bars to the right means that there's an increased risk. So there's an increased risk of mortality in those with low TSH amongst all patients. And we see exactly the same thing for cardiovascular events. So we concluded from this study that there is increased mortality in patients who are poorly treated for Graves' disease, especially in the first 1 year of treatment. And regardless of treatment method, early control of hyperthyroidism is associated with improved survival compared with less effective control. This tells us that there's a lot we can do at the early stage of disease in treating patients prudently and monitoring them and making sure that they are well controlled, and that this will prevent problems later on in life. The second question we asked is, what of patients who do not respond to levothyroxine? This is a study done by Professor Colin Dian's team when he was based in Bristol. And what this shows is that patients on levothyroxine have lower quality of life, or well, higher quality of life scores, which means lower quality of life than matched controls. So patients, this is the GHQ score, and as you go from the right to the left to the right, the increase in GHQ score means worse quality of life. So the patients have more of the higher GHQ scores compared to controls. And this sort of, for the first time, showed that patients on levothyroxine are actually not as well treated as compared to people without the problem. And yeah, you might be familiar with some of these screenshots from the web. This has led to a lot of dissatisfaction, a lot of debate, sometimes anger and frustration, which is understandable if patients are not feeling as well as they should be. So if you look at meta-analysis, and I remember I said meta-analysis is the sort of highest level of evidence. So the meta-analysis that have looked at and this is a recent meta-analysis which looked at 18 studies with low to moderate risk of bias, which is actually a good meta-analysis. It shows that both treatments, if you're using combined therapy with T3 and T4, and if you're using T4 therapy alone, there is really no real difference. You could argue that depressive symptoms were marginally better in those with combined therapy, but there wasn't enough difference in this to say that one treatment was better than the other. It's important to note that both treatments were sort of equal in their effectiveness. But when you now look at preference, treatment preference in that same meta-analysis, you find that the majority of patients prefer combination therapy, with 23% only preferring levothyroxine and a third having no preference. This is the same for one study that had looked at preference for desiccated thyroid extracts, where you find that close to half of patients preferred that, while only about a quarter of patients preferred levothyroxine. So the meta-analysis concludes that there's no difference in clinical and surrogate outcomes, but that patients preferred the combined therapy. Now, these are the guidelines of the international societies, including a British Thyroid Association position statement we made in 2016. I think for the first time, it was recognized that there is a group of patients who are not fully served by levothyroxine. And while more research is needed, combination therapy may be considered for those who do not respond to levothyroxine. But after you've excluded alternative causes of comorbidity. Now, could this be genetic? And I think I saw a question a little while ago on genetics. Could this problem be genetic? I'm not saying all of it is genetic, but it is possible that there is some genetic component to it. T3 is the biologically active hormone, and T4 is a bit like a pro-hormone. So T4 is converted to T3 by the action of T deiodinases. Di1 and Di2 are the common ones. And there's a common genetic variation found in some of these deiodinases. By that, I mean that there are genetic changes, which means that the deiodinases are not as effective as they should be. So do these genetic variations contribute to impaired well-being in some individuals on T4? And studies by Collins Group as well in Bristol years ago also showed that in a very small sample, that those who have combined T4 treatment with the genotype, with the DIO2 genotype, who are homozygous for that, actually had better improvement with combined treatment. This raises the question that some patients with a genetic predisposition may respond better to combined therapy. And so this is the basis of which we set up the genetics of thyroid hormone replacement study. It's called the GENTLI study. It's a South Wales study, which we're doing in One Health Board. And we're looking to see an association between the DIO2 genotype and quality of life in patients with hypothyroidism. So when patients are due for their annual test, we measure their quality of life, measure their genotype, and then look at the correlation between the two. We have about 2,800 patients. We're aiming for 3,000, so we're in course to meet our targets. And we've looked at the genotype of about a third. Some of the very preliminary results we're getting is that there is an association between genotype and quality of life, but only in those who are on high doses of, well, sufficient doses of thyroxine, about 100 micrograms daily. So you can see here that those on thyroxine have higher depression scores and higher general health quality scores, which means worse, they feel worse on above 100. We don't see this below 100. The reason why we're still trying to work out, it might be because those below 100 may not even have thyroid disease in the first place, or those below 100, there are other factors at play. But this is very preliminary and we'll need further analysis. If we're going to be using combination therapy, then we must be thinking of the safety of T3. While T3 was used a lot in the 1950s and 60s, it sort of went out of fashion. And because we haven't used it that much, we don't have enough evidence on safety. T3 is not prescribed as much as T4 in the NHS. So doing such a study in the NHS is problematic because we don't have enough patients to give us a strong sample size. So for this, we've approached a clinic that had treated T3 patients in an independent clinic from 1996 to 2013. So they've got about 4,000 patients. We have them passed all ethical and governance approvals for this, and we're in the process of collating the data. So we're going to compare the mortality in the T3 group with age and sex matched controls who were treated with T4 and with the general population. We're doing this again through data linkage through the SAIL data bank in Wales and NHS Digital, such that the researchers will have no clue as to the patient's identity. So the patient's identity is protected. And in addition, patients who do not want to participate in this study will have opportunities to opt out of the study through the Vaccine Research Trust, who are the data custodians for this. So they can always email or contact the Vaccine Research Trust and ask that their data is not included in this. And there's a notice regarding this on the website of the Vaccine Research Trust. So we now come to the final study I'm going to talk about, and we've called it the LION study. This is courtesy of a generous grant. I forgot to say the T3 study was courtesy of one of the grants that Julia talked about, the BTF grant of £20,000, which has been a real help in getting that study moving. So the LION study is courtesy of a Medical Research Council grant, and we're doing a randomized control trial of T3, T4 combination therapy versus T4 alone. What we're doing differently this time, because there are already 18 studies on this, so what are we doing differently? Well, we're using a T3 formulation that is slow release, which will better simulate the physiological release of T4 in the tissues. And we're targeting individuals with the DIO2 polymorphism rather than the general population with hypothyroidism. We're identifying these individuals from the gentile cohort, and we'll approach them to take part in this study. It's a 24-week study, which patients will receive one treatment and then cross over to the other. And we probably will be able to get this study going sometime next year, and maybe in another 2-3 years, we might have results from this study. So I'm just going to end there by saying, how can you support research? So like I said, we're asking questions at this early stage, this stage of expert opinions and things. So we'd like to know what questions matter to you. And I think we'd like to know what questions matter to patients. We'd like patients to participate in study designs right from the start, not just participation as participants, but right from the concept and the design of the study, because we can learn a lot of valuable things from your perspective. We'd like to see more patients in committees, ethics committees, funding committees, and more patients speaking up for patients in the public space. And of course, like the BTF, we would like to see more funding for thyroid studies. When we have the studies, we'd like patients to disseminate the information to your wide groups and people that follow you and people that you reach to disseminate such information. So I'll just end by thanking all my collaborators, the study participants themselves, British Thyroid Foundation, the Vaccine Research Trusts, SAIL, my health board, and of course the thyroid research group. You talked about Professor John Lazarus. Yes, he was also a mentor of mine, and I think I was a generation slightly below Marian in being one of his disciples, but we learned a lot of thyroid from him. So I'll stop there and take any questions. Thank you very much.
So, Buchi, thank you very much for another excellent talk. I really enjoyed the way that Marian looked in her in vitro studies as a way of generating questions and testing hypotheses, and you've looked at your clinic in a similar way to sort of say where can we identify where people are stuck in a rut or a loop, and how can we use that to generate questions that we can test in these big studies to improve care. So thank you both for such complimentary talks. We've got a lot of questions to get through, and obviously we're not expecting you to be experts in every area of research. So there may be some questions that we might acknowledge the fact that other groups are working on this, and then there might be some that we might focus on in a little bit more detail. And there's certainly a lot of questions on the theme of autoimmunity. But before we come on to autoimmunity, we've got a couple of questions. One about thyroid hormone resistance and what research is being done in this area. I suppose that's a big focus of interest for Cambridge. Is it something that either one of you is particularly expert in, or would the answer to that be yes, there's research being done, but other centres such as Cambridge have more of a focus on that?
That's what I would say, certainly.
Yep. And then
I just wonder if the thyroid hormone resistance being mentioned here, there are two uses of thyroid hormone resistance. So there's thyroid hormone resistance, as in those with the genetic thyroid hormone resistance, but it's sometimes used to imply or denote patients who are not responding to thyroxine. So I'm not sure what the context was, but if it's the genetic one there, that's the field of Cambridge, isn't it?
And then we also had a question about research done on congenital hypothyroidism in children. And again, I don't know whether either one of you wants to talk at all about sort of some of the work done on sort of maternal outcomes, children, or defer that on to research being done in other areas. Buchi, do you want to comment on any
well,
work?
it's not quite my area, but I also know that the sort of problems we have in the adult treatment of hypothyroidism, you do have that in congenital hypothyroidism. So you have patients that are fully well replaced with thyroxine who still have, lots of residual symptoms. So I think a lot of that will apply, but I must confess it's not my area of expertise.
We have a, sorry, Marian.
From the point of view of research, I mean, I think that the genetic causes of congenital hypothyroidism have been identified in many cases, but I believe that despite all the best efforts, there's still a vast proportion of congenital hypothyroidism where the genetic cause has not been identified. So there are more things to learn.
So we had a lot of questions on the broad theme of autoimmunity. One of the early questions I think has probably already been answered, and somebody said, are there human studies on females? And I think, Buchi, you've spoken at length about how autoimmunity is more prevalent in females. And I think really when you're recruiting participants, they would reflect the spread of patients that you see in your clinic. So presumably the majority of your trial participants would be female. Is that correct?
Yes. So for hypothyroidism is about 8:1, and we found that kind of ratio, 8 females to one male. In hypothyroidism is even slightly higher, it's about 10:1, and that's exactly what we're seeing in the Gen5 cohort.
And delving a little bit further into the autoimmune question, I think this is really going to be a question for Marian. We've got a question here about whether there's a link between the gut microbiome in those with celiac disease and those with Graves' disease. Obviously, if you've got one autoimmune disease, you're more likely to have another. And so has any research been done comparing gut microbiomes between different autoimmune diseases, and how much do we know about that?
It's certainly a very good question. One of the things that we did within Indigo was try to get a feel for the proportion of individuals with Graves' disease who also have a problem with celiac disease, I think that the proportion that we found was slightly higher than had previously been reported. And we are certainly in the process of looking to see whether these individuals have a distinct microbiome from those that have just Graves' disease. So it's very much pending. There should be results soon.
And then we had two very similar questions about treatments, again, on the theme of autoimmunity. One was, let me just find it here. Yes, one was really just referring to the fact that the FDA has recently approved a therapy to slow the onset of type 1 diabetes in patients who screen positive for autoantibodies, and wondering whether there was any similar research in Hashimoto's specifically. But then somebody else has also asked about whether, yes, is anybody looking at inducing tolerance towards the TSH receptor to reduce the incidence of Graves' disease through primary prevention, similar to the oral insulin trials for type 1 diabetes?
I mean, sort of taking the idea of what's new for treatment of Graves' disease collectively, there's some incredible work going on in Newcastle at the moment, using small fragments of the TSH receptor. It's called antigen-specific therapy, and that's led by Simon Pierce, and that's had fantastic outcomes. There's another really exciting development that was made from researchers here in Cardiff, Bernard Rees-Smith and Visha Firmaniak, and they've managed to isolate a monoclonal antibody from a person with Graves' disease, but instead of stimulating the gland, it blocks the gland. And when they put that into people, then their Graves' disease gets a whole lot better, and their eye disease gets a whole lot better as well. But this is still, you know, it's a first clinical trial. The results are amazing, but really very encouraging for the future.
Yes, and in fact, we had another linked question on that theme, asking, can we bring autoimmune antibodies down? But I think really you've sort of alluded to a lot of the work that's going on in that field. So a lot of research interest and some promising avenues for us to look at. We had some other questions, I think, on autoimmunity. Here we go. Yes. So somebody had asked about blocking and stimulating TRAbs. So how easy is it to find patients with blocking TRAbs? And I suppose a linked question, somebody had asked, can you be both hypo and hyperthyroid?
I mean, I think in terms of the antibodies to the TSH receptor, we have assays which are able to distinguish the stimulating from the blocking, and one does see individuals where both are present, and then whether the person is hyper or hypo will just depend on which is the more abundant. I mean, in terms of the clinical outcome of that, Buchi, you're probably better placed than I am to say whether someone can be both hyper and hypo at the same time.
Yeah, we do see patients who move from one to the other. So we see patients who start off being hyperthyroid, and then without definitive therapy, they become hypothyroid, and years later, they become hyperthyroid again. We don't always have access to blocking antibody tests, so we don't know if they've got blocking antibodies or not. But yes, theoretically, patients can be hyper and hypothyroid.
Yep, likewise, I've certainly had a couple of patients who've had hypothyroidism in the past and then presented with thyroid eye disease, and then we've tested them and found that their TRAbs are positive, and then not all of them, but some of them have then go on to become hyperthyroid. So another area of interest. There's also a lot of questions around the sort of T3 and deiodinase issues, which I'll maybe sort of channel towards Buchi. So one question here, Buchi, is why can't all patients diagnosed with Hashimoto's be tested for the DIO2 gene? Should they also be tested for celiac disease? So what are your thoughts about broader testing for deiodinase genotype?
Okay. For the celiac disease, yes. So there is a link between celiac disease and other autoimmune diseases. So there's no harm in testing for that. I think for the DIO2 gene, the evidence for Hashimoto's, the DIO2 gene in Hashimoto's it's not there yet, because it's not a cause of Hashimoto, the DIO2 gene. I think if we or any other group can show that those with the DIO2 gene have worse outcomes in terms of quality of life and that this can be improved, yes, then we could get there, but I don't think we're there yet.
Great, and we're sort of rapidly running out of time. I don't think we're going to get through all the questions, but I suppose a couple of linked questions that might be quite good to end on. Buchi, you'd spoken in principle about how people with thyroid disease might become involved at various different stages of the research process: study design, participation, dissemination of results, ethics committees, etc. So one viewer has asked, how can we volunteer to be part of a research study? And then another one has said, I have just discovered I have the worst DIO2 genotype and would very much like to participate in any trials. How do I find out about them? So I suppose in general terms, how do people go about finding out what studies are ongoing? What can they volunteer for? And as a linked question, somebody also said that they would have been suitable for a previous trial in Newcastle, but it was too far to study, too far to travel, and it would be great if patients could go to other centres for collection of data. So just your thoughts about how people can sign up to studies, how centres share data, how we can, I guess, open up the doors for participation in studies more broadly.
So we would like as many people as possible to participate in studies. And my experience with thyroid research is that this is one area where you have willing participants and willing patients. The studies we are doing for administrative reasons, we've sort of kept it within our health board for now. And it is possible that in due course in time, we will roll it out to other parts of the country. Now, we tend to work through as organizations like the British Thyroid Foundation, who will know what studies are available and who is recruiting. So I think that would be your contact, but would also depend on what area you are. So if you were in our part of South Wales, and yes, you could be approached, or you might be eligible for the current trials we're doing. But if you're not in that part, then it's perhaps your best bet is to be in touch with the British Thyroid Foundation, who know which studies are being done and which studies are recruiting. So that would be one way of getting involved as a participant, but you can get involved in other ways, not necessarily as a participant, but as somebody who is on a committee or somebody who is contributing to things, contributing to the research design. And that again will be through bodies like the British Thyroid Foundation.
Thank you. So we're a couple of minutes over time, and we've probably got through about 2/3 of the questions, but there's still quite a lot, but we'll probably need to draw it to a close there. Thank you both for a really stimulating talk. You can see from the number of questions you've generated that people have really enjoyed and responded to your talks. I've certainly really enjoyed hearing about all the examples of research that are going on. And I suppose really just to follow up on Julia's earlier plug to say that from my point of view as a clinician, the British Thyroid Foundation provides fantastic information and resources for patients, but we've also heard about how they fund research, including research that you've been involved with, Buchi. So I think if people don't have a research study that they can take part in near them, actually joining the BTF is a way of indirectly supporting research through the broader work of the BTF itself. I think we'll try and answer as many of the unanswered research questions as possible subsequently, but it really just remains for me to thank both speakers for two really stimulating and excellent talks. Thank you very much, both.
Before we end, can I just say, if there are a few questions that have not been answered, would you contact BTF with the questions and then they can contact us to answer them? Would that be useful?
That's absolutely fine. There's a, I'll put my screen up now. You'll see there's a, hopefully you can see that on the screen now. There's an email address that you can send any unanswered questions to. Thank you so much to Marion and Buchi for your such fascinating and wide-ranging presentations, and also to Nicola for your excellent chairing and for leading the discussion. There were so many excellent questions that were raised, and you can see that there were some we didn't get around to answering, so please get in touch with them and we'll try to do our best to answer them, and I'm sure our speakers would be happy to help. The talks were really such a great, fantastic tour de force of all the things that are going on in research now and have done in the future, and I think I'm encouraged that the future is looking bright for thyroid disease, and there are lots of interesting things going on across the board, across the country at the moment that hopefully will improve outcomes for patients before too long. If anybody joined late or there are bits of the webinar that you missed or would like to listen to again, there will be a recording added to our YouTube channel just as soon as we can get it up there. If you go to the YouTube channel, you can find all our other webinars as well from the previous 2.5 years. And if you would like to contribute to the BTF research appeal that we're running this year, you can follow that link on the screen now. There's a Just Giving page where you can donate. This will be our 25th research award that we're hoping to give out next year. And it will be really wonderful if we can boost things so that we can encourage the continuation of these awards, which Marion and Bushi have both been recipients of, more than one, and we're very proud of all the work that we've been able to support. Just a final plug for our next webinar, which is taking place in January. If I can get the screen on there, the next one is about thyroid cancer, Tuesday the 24th of January. You can register through that by contacting us. Unfortunately, our main website is down at the moment, but we're working hard to get that back on track. And the holding website there gives you all the ways that you would need to contact us anyway, so hopefully it won't be too much of an inconvenience. So thank you again to our wonderful speakers for giving up their time tonight. They're all extremely busy, and we're very, very grateful that you found time for us. And finally, a huge thank you to all those who joined the webinar, who are still left listening to this and asked questions that made it such an interesting meeting. So please stay in touch with the BTF, and we look forward to seeing you at future events. Thank you and good night.
Thank you.